has a little bit of the program that I think has been alluded to, having a behavioral health professional in the jail, coordinating with folks who have mental illness, and making sure they get the supervisor and the sheriff mentioned that warm handoff, not here's a card and good luck to you, but making sure they're connected to services. Laura's Law has also been very effective in the community-based treatment. We're now gathering data on that. Also having a crisis residential facility, it helps fill in that continuum. I think that's been positive. The crisis stabilization unit that Dr. Shipper referred to, that's going to help a lot. There are 4 chairs. The plan is to double that in the next few months. So we need more of that, so we're going to get more of that. Another area I want to just touch on too, the RISE program, so that expansion. So it's been working, but now it's going to be expanded, and I think to law enforcement agencies, including our sheriff and police departments in Ventura and Oxnard and CV and so forth. So it's a model that works, and so why not do more of it? And the last thing I'd say is, a lot of folks also are homeless, and so what are we doing about that? And our board is partnering with a couple of cities, and has made this offer to all of the cities in the county actually, to help fund a permanent year-round shelter. And to get folks off the streets, housed, and services. And so we're very pleased that we are in the process of funding the startup costs, we're splitting the startup costs and the operating costs for the shelter in Ventura at a former county building. And then we have the same plan, that's about 55 beds. We have the same plan in Oxnard to fund that year-round shelter with about 110 beds. And again, services for those facing mental illness will be there, as well as drug and alcohol services and medical services as well. Thank you.
Thank you. So we touched upon some of the things in question number 2, but if we could elaborate on any current policy priorities that maybe have not been shared yet. I know that there was talk about the pretrial diversion program, and so maybe talking about what that looks like for Ventura County. It's my understanding that some counties are not currently implementing it just yet. So I would be curious, where did you start? And then what is working, what isn't working, how we can support. So question number 2, what are our current policy priorities in decriminalizing mental illness and providing mental health care for individuals that unfortunately are in the criminal justice system?
I mentioned our crisis intervention team model, and that has primarily been focused on our patrol resources. Most of our patrol deputies and officers around the county have been the primary focus of that training. And it does kind of make sense. They're the ones that deal with people that are in acute crises and dynamic situations and uncontrolled environments. We're now in a position where the majority of our patrol officers and deputies are trained, and we're focusing now on our dispatchers and our jailers. So we have deputy sheriffs that work in our jails as well as civilian employees. And we're looking at training those folks as well as a means of helping them interact effectively with those folks that do wind up in our custody and care. Something we're doing locally as well is we are in the initial stages of building an addition to one of our jail facilities. It's a 64-bed health and programming unit. It is designed to give us accommodations to help address acute medical and psychiatric care in our facility. This is a really big addition for our jail system locally. We have minimal ability to provide that sort of care currently. We have about 1,650 inmates on average count, and of those inmates, about 44% are on psychotropic medications. So I don't know that equates to 44% being mentally ill, but I can tell you that 44% are medicated. So there's a pretty significant component of the folks that we deal with in our jail system that have some form of mental health issue that we need to deal with. And hopefully when this facility, our Todd Road Jail facility is ultimately built, it'll give us more capability to deal effectively with those types of issues in our jail system. Yeah, the question was, is there a time frame? Yes, it was supposed to start last month. It's been in the planning stages it's unbelievable how long it takes to get a project like this off the ground. We're waiting for our state fire marshal to give us approval to begin geometric design that has been proven in other facilities around the country, around the world really, to contribute to a therapeutic environment. So we're really, really excited about that. We think it will be finished in late 2021. Okay.
One thing I would say about that too is that this was kind of unique. Most of the counties in the state really simply went with larger jails. This is one of the very few that was focused on a facility for those with mental illness and medical challenges. So, and I think that's why the state agreed to fund 90% of the project, which is pretty spectacular. The mental health diversion program. Oh, I'm sorry. Go ahead.
I serve on the Nami helpline.
Yes.
And the number one question from parents, especially those out of state, is where can my family member with more severe mental illness go as soon as he's released either from the jail or the hospital? That's the number one helpline.
Well, and that's a little bit what we spoke about earlier. There is a program with the jail liaison. A member of behavioral health team is in the jail coordinating for just that reason, to make sure they're not just released and don't know where to go and aren't connected to service, that warm handoff. Yeah, absolutely. Go ahead.
And then also to ensure that they get hooked up into our county's behavioral health services too. And then that will enable them to be able to look for placement and all that too. So that's a real key.
Absolutely. Yeah, that mental health diversion program, I think it's actually going pretty well, really, partly because the mental health court program has been ongoing for so many years. The infrastructure is there, the departments are very used to working with each other, the courts, DA, public defender, probation, behavioral health, sheriff. So it's really kind of formalizing the protocol, so that is working. I would also say another area that we're really, our board and our county is focused at is trying to support permanent supportive housing. And there is some, but there needs to be more. And that's a real policy area where we're seeing that helps individuals with mental illness, homeless, and so forth. And so the No Place Like Home funding, one of the things that Dr. Johnson is doing in the behavioral health department is getting out to the cities and the development community, letting them know what funds are available to support these kind of projects.
I really appreciate you sharing that. That's something that I think across the state, housing is an issue in each county. Some counties obviously have more populations to deal with. But the state organization was in support of No Place Like Home. This was passed in 2016. We're now in 2019. And so I think the next thing for a state office is to support individuals at the local level with whatever stakeholder process is for the No Place Like Home. And so I really appreciate you sharing that.
I would just comment also that, and I think the sheriff would agree, that a lot of the people that are in our jails with mental illness, the types of things that they've been arrested for are not violent crimes. They're things like trespassing and intoxication and these kind of, and where it is apparent, it would be wonderful to be able to continue to have other options available. And that's where we're looking at, for example, the CSU and 23-hour beds, let them detox and get them services. So that's really, I think, an essential part. It's really expensive to put someone in jail, and it's a lot better for the system and for the health of our society if we can have treatment instead of incarceration.
I agree. So now we're on question number 3. And so if you have not already jotted down some questions that you have for the panelists, please do so shortly. So question number 3, one of my favorites. How might stakeholders utilize available information and resources to advocate for more diversion, prevention, and early intervention programs that get people into treatment rather than incarceration? I think that's a very long question, but very important.
One of the things that I think is important in that is that people should realize that their input really matters and that they can really make a change. And I think about an individual on our mental health board who found services that they thought were really key in a community that they had been in, I think in Arizona, and introduced them to our county, and we incorporated them. We were able to use that. We saw another program in San Luis Obispo, right? And we saw that was really working there and pushed to get that through. So it's not just government trying to solve these really difficult problems, but I just want you all to know that you have ways that you can provide input, you can make a difference too. And I think one of the things that I've put together is a mental health and safety task force after we had the mass shooting at the Borderline Bar and Grill. And one of the things that we're looking at is to get input from the community, that you can give us your suggestions on what things you think we can do to avoid these crises. Because there are some really excellent models out there. We don't know all the answers. So I think that's one of the ways. See what works, see what's going well that you know of, bring that forward and help us to all as a community, as a village really, to be able to solve this really intractable problem.
Please tell what that non-is.
Yeah, it is. The mental health and safety task force includes a representative from Nami. We also have representatives from our veteran services, other cities. We have a city manager from Thousand Oaks that's on there, but we want to be all inclusive. We can't have everybody, and that's why we want people to be able to give us the information that we can share to the task force. We look forward to bringing that report back at the end of the year, so the public has an opportunity to hear it and comment on it too, because there are definitely some things that we can do better. And I think part of this task force, for example, is looking at how to streamline our services. When someone's in crisis, we don't want that to take a long time. The hospitals don't want those people waiting in the emergency rooms. We need to do what we can, and part of that really is seeing that, for example, we have more inpatient psychiatric unit beds. We need more beds. We're low nationally, right? There's on a national average, they say you need about 40 to 60 nationally. I think it's about 17 here in Ventura County. It's 10 beds per 100,000. So looking to see how can we increase the number of beds. And I know Mr. Powers can talk about what it used to be, and I know even before they, opened up all the mental hospitals, there was something like 365 beds per 100,000, right? We're down to 10 here.
But you've got it exactly right, Supervisor Parks. Maybe 15, 18 years ago, there was over 270 inpatient beds in our county, and now it's down to 30 in our unit, and Vista has some as well, but that's it. There were 2 hospitals in the East County, 2 additional, there was another 2 or so in the West County, and so it's one of those things where we have to have that community conversation. And what I appreciate is the relationship we've had with Nami over the years, and it's just very productive. It's sitting down across the table trying to understand things better. I'm looking at Mr. Nami, but in the meetings that we had with you and Nami leadership, as well as the Behavioral Health Board on the need for the mental health rehabilitation center, the MHRC Horizon View. We had those meetings for years, and now we have it. But it's also helping to prioritize things. There's a lot of issues out there, right? And legislation comes along and it changes, and not everybody understands that. Even just talking from an administrative level, it helps to educate people about what's needed, what is available in terms of funding and programs, what's working, as the supervisor said, what's evidence-based practice. This stuff is complicated, and the more we prioritize and highlight and educate and simplify, because when it gets confusing, it gets hard to advocate effectively, I think.
Excuse me.
Yeah, and then, like I would say back on the permanent supportive housing, I think that's another one where the more we educate and talk about things like here, on the homeless piece, we're putting a lot of pieces in place. Homeless prevention, rapid rehousing, that's the rental assistance program. We've got like 1,500 people in our county on that program. People don't really realize that. And it's not just a Band-Aid. 80% of these folks stay housed 1 year later. So it actually really stabilizes their life and allows them to have sustainability going forward. And but what don't we have? What we don't have is that permanent supportive housing, and we have a need for more board care facilities as well. So I think it's really distilling down those key priority areas and working in collaboration as you have with our policy leaders and our department experts as well in the area. Thank you.
Awesome. Thank you. So I have had my first question trickle in from those in the crowd, but I first want to, if you have any final thoughts, I always like to, before we jump into questions from the crowd, any final thoughts that you were going to share kind of with advocates, sentence or two, that would encourage them to continue the conversation as it relates to access to treatment and advocating for mental health services.
I just wanted to add, there's a principle of leadership. If you study leadership, it's called leadership by walking around. And that's in essence, getting out and talking with people and seeing operations and how they work and so forth. And when I do that within my organization, I hear things that people will bring to me, and I'll say, we do that, or we don't have that. Why is that? And I didn't know that. We're a large organization, and the people that are actually doing the job are seeing deficiencies, and they think we're just ignoring them. So there's experts, filling this room here that I think in some cases probably believe that we know the issues and are just not doing anything about them or responding to them. So I encourage you to speak up if you see something that you think we can do better, what that we're doing that we shouldn't be doing. I want to know. I want to know about it. I don't have all the answers, and I think that hearing from people in the community, particularly that are experts on the subject matter, is really valuable to me. So please do speak up and let us know.
I would just say we need you. Bottom line, you bring a perspective to the table from the family perspective that we may not have. And so please share that with us. As the sheriff said, part of our county is we embrace continuous improvement. We know we can do things better, and that's how we learn is by meeting with you.
Just a comment I have too from the advocate's perspective. You realize that there are some mental illnesses that if you catch them early, you can really work and prevent and save people's lives. And so that same kind of aspect, if you see something, say something. If you are working with the schools, for example, a lot of that is the transitionally aged youth and, for example, schizophrenia. That's something that can be prevented as we see the markers towards that, and what a huge difference that kind of thing makes. Also, I had mentioned we do want your input, particularly if you think of ways that we can assist in crisis situations. That website it's called bcrecovers.org, and you can go onto that and fill out a form. You can do it anonymously if you want to, on ways that you think that the system can be better in particularly working to prevent crisis situations that can lead to violence. So that's one way that people can participate. That's bcrecovers.org.
Awesome, thank you. So I do have a couple questions here. I don't know if we'll be able to get to everything, and so I think I'll work with the local affiliate to share those, to see if we can address those maybe at a future meeting. But I want to be mindful to make sure those questions are answered. So the first question that I have, over 60% of inmates with mental illness have co-occurring disorders of substance dependency. What treatment is there in the jail and in the community for co-occurring disorders?
Well, I'm not sure I can answer that in sufficient detail to satisfy the question asker. What I can tell you is that we have a contracted medical and mental health provider in our jail system that provides attention and care to all inmates in our custody. And we have a doctor of psychiatry that comes in and talks with inmates, particularly those that are on the list for psychiatric needs, and that occurs daily. And there's a medication assistance program in the jail that inmates can opt into. So there is a fair amount of care that's provided. And like I said earlier, when we add our facility at our Top Road jail, we hope that really expands our ability to provide quality care.
I would just add to that the behavioral health department, Dr. Schiffer will correct me if I wander off here, but that's a big part of their approach is dual diagnosis, treating the conditions together. And they've identified that years ago, and that's a big part of their program. And as I understand it, as the sheriff alluded to as well, they do have medication-assisted treatment in the jail. In fact, they just updated some of the medications they can use. One of the first jails, I think, to start using the Ventura, I think. And so it is something that they're looking at in the jail.
And I would also think that when you're in jail, you end up getting clean. If you are both mentally ill and you are addicted for that period of time. And I would also think that really makes it very challenging for our
Okay, awesome. The only reason that I'm going through these is because I know that every county that I go to, these are questions that I hear. So I think that a lot of individuals out in the crowd probably have similar questions. This one is very interesting to me because it talks about incorporating family member. So many clients are released from jail and inpatient unit and are essentially sent back to live with their families. Does the jail liaison include family members during the planning for client's release? And I would assume in situations where when you can include family member, you do, but
Yeah, I would agree with that. I would think that's the case as well. That's typically something we defer to the liaison who is not here on the panel. But that could be certainly a component of the successful release. That's something we really look at these days, is that successful reentry into the community with the hopes that there's a reduction in recidivism rates. So in some cases the family can be helpful, in other cases not so much.
and I think that really points to utilizing things like Nami to educate family members on the rights of the client, how to access services. So there's a lot that we can do to raise awareness and include family members' benefits. Yes.
I might just say that we're always in a position to receive information from family members, and in fact, we're always in a position to receive information from family members. And actually, there's been a form in place for several years now. You can actually find it on the public defender's website, and it invites family members to speak to their loved ones' current treatment, past treatment, including medications, and it goes directly to what's now WellPath, WellPoint. They changed the name recently. The medication provider the sheriff contracts with in the jail. So, indeed, one of the frustrations that we have is very often wanting to involve family members and knowing that, of course, a person's success to a large degree is influenced by their relationships with their family members. We inevitably have to take our lead from the client, whether they will or they won't give us consent. I will say that when we don't have consent, what we try to do is nonetheless provide information in a general manner that's intended to be helpful and pertinent, but without necessarily breaking somebody's confidentiality.
I was going to suggest that Dr. Shipper already has a mic in his hand. Maybe he could join us up. Sorry about that, John. Thank you.
So this question, it might be specific to the sheriff, but I think that
John,
Yes.
they can attend the meetings. They can attend the advisory meetings. Oversight.
All right, to you, yes.
Encourage.
So, the Behavioral Health Advisory Board has a series of different, that's the Behavioral Health Advisory Board, has a series of different service committees. So there's one for adults, there's one for prevention, there's one for transitional age youth, and as being alluded to, there's always room for more people to come and attend, and it's as simple as regular attendance will make you a committee member. So be advised about that right up front.
But you have a voice in what programs are put in place.
And we'll share information in a follow-up email. So I'm really big on emails. You might get too many from me, but you'll never not know where to find something. So I'll share that with you. And we'll work with a local affiliate to, if we need to hold additional meetings. And that's kind of the beauty of the regional meeting, is you identify who maybe wasn't involved in the conversation before. Maybe some folks have dropped off and now are coming back. How can we continue the energy and the positive moving forward? So I'll say that. Next question that I have is very specific on treatment centers. So, how many treatment centers for mental illness are located in Ventura County? And then there's a second question: how many jails are located in Ventura County?
I can take take the second one. We have 3 jail facilities. One is a small holding facility in Thousand Oaks, 32 beds, I believe, and it is used primarily for low security trustees. They do work around the community, so no mental health services or any real medical services are provided there. We have 2 larger facilities, one at the Todd Road facility between Santa Paula and Ventura in the unincorporated area. It's about 800 beds. And then another main jail facility at our government center campus in Ventura, which is about 850 beds. So our total jail capacity is about 1,686 beds.
And on the mental health side, I can speak probably for this purpose. Specifically, adult clinics, we have 6 adult clinics spread throughout the county. We have one in Simi Valley, one in Thousand Oaks, 2 in Oxnard, one in Ventura, and then one in Santa Paula. We have, of course, the crisis team that responds county-wide, and then we have the RISE program, which Mr. Powers is alluded to, which is also a county-wide outreach and engagement service. And then we have other programs, Transitional Age Youth, which is located in both East and West County, and an Older Girls program, which is based out of Ventura. Yeah, well, I mean, yeah, in terms of the wide scale, then we have contractors that are providing any of a range of different services. Some of them, like ours, are outpatient services. So Telecare provides the VISTA program, which was indirectly alluded to, about doing that outreach and engagement with jail and connecting people upon release with either immediate housing or follow-up services. We have Telecare also operates in part the Casa de Esperanza program, which is essentially a collection of casas that are 15-bed, essentially board cares. There's also a new contractor, Golden State, which has assumed responsibility for Hillmont House, which is on the same campus as CASA. And it's actually the state's only unlocked mental health rehabilitation center, also 15 beds, and commonly serves as a step down from either an inpatient unit or from locked placement. The Rising View, which is our newest addition, is a locked mental health rehabilitation center, not far from CASA, but not on the same exact campus. That one is 16 beds. We've been in operation for, I think, it's approaching 3 years. And then we contract outside of the county for other either board care or locked placements. So, and on the order of what the sheriff was saying about any given day on the adult system, we have about 4,500 enrolled clients. In terms of kind of outpatient services, excluding crisis team, we usually have about 6,000, in the order of 6,000 unduplicated contacts.
That's a good question. I just want to ask, is the youth authority juvenile center on Vineyard, is that because it's juvenile, considered separate from the adult, and that's really in jail?
It is. So probation operates the juvenile justice center. They have to contract with B, but also we have some staff that work in that setting. And any other specific questions? The best expert is in the back row.
You know,
Probation, Mark Brown.
if I may, thank you for that question. When you were looking at models of how to do better, I think the probation model has been proven very effective in their juvenile facility, and I think it starts with that community collaborative approach with probation, DA, public defender, behavioral health, Boys and Girls Club, Girls Inc. The list goes on and on. And they have mental health providers in the juvenile facility, and they really want to connect folks, before they re-enter the community. And I think they do a beautiful job of that. And they have a problem, and I put that in air quotes, forgive the air quotes, which is that the census in this juvenile facility has dropped dramatically over the last 10 or 15 years. And they're too humble to say it, but I think probation has a big part in that. I think law enforcement does, because not every child behavior problem in a school requires connection to the justice system. I think is the way they look at that. And then that, just by itself, diverts a lot of folks who never, don't have to end up in the juvenile facility, or maybe take a different path. So, you know, and they also have crisis stabilization units. We opened one about 4 years ago in Oxnard. And I think all those pieces together are showing that this kind of approach can really be effective.
This question is specific, I think, to a population that we haven't really focused on today as much. But what is currently in place as relates to services, resources for the aging senior population who live with serious mental illness? Folks tend to get left out of the conversation a lot. That's also a very important population.
Excuse me, we need a peer on the panel. Because the statistics has gone down, because we have peer programs in place. Let's see the statistics 5 years from now without that they've been mixed out, all the transition programs. Now let's see where the statistics are without it.
We can plan for the next one.
Thank you.
So, Ventura County Behavioral Health operates.
The microphone.
Sure.
Thank you.
Ventura County Behavioral Health operates a older adults program specifically, which is MHSA funded, and it's considered to be a full service partnership, which basically means those are intensive services. In this particular instance, that intensity is kind of reflected in the fact that it's mostly field-based. So the number of clients in that service are usually in the somewhere between 90 and 100. So it's a relatively small program, especially given the size and the aging population. And so those services at that level are usually constrained to people who are either homebound or have trouble ambulating, so that it's either difficult or sometimes impossible for them to get to the clinic for service, so we bring the service to them. That said, there are certainly way more, I don't know the number, but there's way more older adults who are receiving services through our clinic and basically get the same array of services. I will say, recognizing that we've actually got a group that's being piloted in the Ventura clinic that is specific to folks of an age, and recognizing that the challenges and the life experience is different, and that commonality is probably a benefit that we haven't tapped, but we're interested in tapping, bringing folks of that age together.
Go ahead, Supervisor. I was just going to say we have Monique Nolan, who's the Deputy Director of our Area Agency on Aging here. Maybe she can touch on a few issues if that's okay. Thank you, Roberta, for the referral.
Thank you. Yeah.
Oh, I was just going to say that one of the things that we're looking at now is specifically there isn't a place in the county that has residential care for people, older adults. And that's something that we're looking at right now with our New Place Like Home funds, that maybe we could build something like that, because we know it is a what do you call it, the silver tsunami, right? More older adults are coming on, and a lot of us sitting up here too and out there. So that is something that we do need to focus on. We have, residential for youth. We need to have that also for older adults too.
Yes, and if I could add that we have at the Area Agency on Aging quite a few supportive services for these individuals to stabilize them and keep them in homeostasis, for housing, the home share program, for supportive services for food insecurity, and some of the other areas where they need support to keep their mental stability. And we're also partnering, engaging in some additional endeavors with behavioral health so that we can provide more supportive services to this aging population. Because as you know, this tsunami is here, and pretty soon seniors in this county and nationwide are going to surpass children under the age of 18. So it's a growing issue, one that we need to continue to face head on and provide strategic plans and initiatives to have in place with this issue.
I might just add, there's a what's called the Rapid Response Team, which is an interagency collaborative, and it's really what I think everybody would want to believe your government does, which is work together in situations that are usually very critical, very alarming. We're talking about seniors who are oftentimes the subject of fiduciary abuse or sometimes even physical abuse, and it's an interagency collaboration, including law enforcement, and cases that basically garner their attention usually get the kind of outcome that we would all hope and want. And again, it's adult protective services do great work, but everybody does better work when you have sort of that interagency collaboration. And it's one of those things where if you show up to somebody's house with a police officer, sometimes things happen that otherwise don't happen. So it's good. It's drawing on the strengths of all those different agencies.
And John, you bring up a very good point, because the seniors in the community don't care if we work for this agency or that agency. They just want help. And so it's really important for us to strengthen these collaborations and to have these forums where we can work together.
Thank you. We did have a hand raised in the back.
Yes, I wanted to just mention that when I work on the helpline, I'm told by family members, especially the aging family members of an aged family member, like someone who's 76 working with their 57-year-old child, that if there is a co-occurring physical illness, that they get sent out of the county. And so if there is, for instance, just take me for instance, I'm not saying, I'm not a mental health patient so far, but my daughter, who's in her 30s, has a 3-year-old. I'm disabled. Let's say I get Alzheimer's or some other form of dementia, and the facility that I would go to if I were caught, doing something that I shouldn't out in public, then I could, because I can't walk, be sent out of the county to another facility where my daughter, the 3-year-old, could help me as readily as if she could come to me. So that is something I just have to think about addressing too.
And that speaks to the point that in addition to having too few psychiatric inpatient beds in the county, we have no psychiatric inpatient beds that can address geriatric patients. And it sounds, on the surface, it sounds discriminatory, and the reality of that is that a psychiatric inpatient unit can sometimes be a place that is challenging, if not actually dangerous, for somebody who has trouble ambulating, or somebody who's maybe 70, 80 years of age who has a need to be there, but is going to find it difficult to get their needs met in a context where the average age otherwise is maybe 30 and so yeah, we need more psychiatric beds. We need again the return of, because we used to have one, but the return of the geriatric inpatient.
I'd just like to add that I was in a SNF, a skilled nursing facility, when I first had serious knee problems. And I was in a SNF where I was put with another person who had Alzheimer's at an early age, like in their 50s. And that person was coming over and messing with the bandages on my leg after surgery. So that's a problem out there in the SNFs that I'd like to make you aware of too, that could be avoided.
So one population again that we haven't really touched upon, but I know Linda, you did share some information as it relates to the effectiveness of intervening early on as opposed to when a situation becomes a crisis. So what currently is the county doing to increase prevention services, especially in schools, to assist with this?
Well, I do know that the county works very closely with the schools, and the schools actually, if you'd like to talk to it, contract with the county to provide services into the schools. And that is a really important aspect, because oftentimes we are talking about youth. If you'd like, you have some comments to make on that.
I was just going to speak to I want to hear what you have to say, but I would speak to the fact that there is, first I should say, there's a range of preventive services that are in place in the county as part of our alcohol and drug programs. And they do excellent work, and you see a lot of evidence of that. And we're a little bit more challenged on the mental health side. The exception being an early intervention program that has actually been in operation for, you're pressed to know this exactly, but probably getting close to 8 or 10 years. And it is attempts to identify young folks, usually prior to the age of 18, who seem to be showing the signs of serious mental illness, thought disorder, of that sort. And it is a challenging population to address the needs of, because sometimes it's a little bit hard to identify those things at the early stages. And then frankly, once they seem to be more clear, it's a challenge to sort of come to terms with what that means, both in the immediate future and the long-term future. So it is hard, but frankly, that program struggles to identify appropriate folks, and it draws heavily upon outreach and engagement. And it's one of those things that even if you're successful in raising it to people's awareness, people still understandably have some reticence to sort of acknowledge, yes, my 16-year-old seems to be showing the signs of a thought disorder, and I'm going to address that face on. We're all given to some amount of denial. I put myself amongst one of the heads of that pack, and it's really challenging to get people to sort of look past that denial and consider the possibilities, because like the supervisor was talking about, if you can get in there early and if you can address symptoms and episodes before they happen, or for that matter, before they're allowed to sort of go on, the outcomes are much better.
I just wanted to mention that the Ventura County Office of Education has a lot of programs in the schools, and they're very active with substance abuse and mental health, and they have a lot of outreach to youth. So I just wanted to mention, give them a shout out.
Can you share briefly how maybe the families are included with that process?
Actually, if there's anyone from VCOE here that could, okay.
Do. Thank you.
There's another item.
Okay, my name's Claire Brown. I work in the Mental Health Services Act. Normally Kim Sahota would be here. She's not available right now. So we do have a lot of prevention programs, and actually I'm the program administrator for the mental health. And what Dr. Shipper says, of course we could have more. We have in the Santa Clara Valley, we have some for the youth, which is one step on the best. They go into the high schools, they educate. They also address the LGBTQ, they engage the parents, they have a drop-in center. So that's in Fillmore. And then in Santa Clara, we have Project Esperanza, which also targets the families. And the cool thing about that is that the provider is the church, Our Lady of Guadalupe. So they have access to all the Latino families. So one of their outreach is right there in the church. And theirs is targeted towards families. They have parent education, parenting classes. They have preventive activities for the children as well. They try to target them. They get referrals from the schools. And then we have Logrando Bienestar, which is another program targeting Latinos. And I'm not an expert in that one. It's not an MHSA program, but I am aware that they are in one of the schools in San Paula, another one in Oxnard. And they also provide education in Spanish to the parents. And then they actually have some office hours there, and they either refer the kids to counseling there, or they get it from the counselor, and then they can also do referrals to BCBH as appropriate. And then with respect to VCOE, we do realize that there's a lot of potential and opportunity within the schools. So right now we're working on a contract with VCOE for prevention and early intervention. And I'm not sure about all the specifics because we're still reviewing their statement of work and budget and so forth. But that one also, it's VCOE is managing it, and they've got a lot of schools are participating in that. So I'm not really sure yet how that's going to roll out. But we are making some headway on that, because part of the MHSA thing is you get them early on, and like Dr. Shipper says, education, reduce the stigma to bring people in, and then also the early intervention programs that we have, and NEAF is one of them. We also have clínicas, we fund them, so that when and this is mainly Latinos, when they come in, if let's say, for example, they say they have diabetes, but the doctor notices they have some depressive symptoms, they bring in a therapist or somebody to talk to them, so then they connect them to that, and that's for depression and anxiety. So we try to get them early on. So we do have, and then I think the eating disorders one is another one for the youth. That one is also an early intervention program. And I know I'm missing one, but anyway, I think I'm giving you enough. So have you
Excuse me? there's a couple people in front of you, so
Oh,
I can get to you.
can I just say thank you for all that you do? That's what I want to say. Thank you. I'm humble. I come off a little strong because I'm passionate about recovery, but I truly appreciate all the time and effort. And
I do also want to say that Nami, Ventura County for years has been in the school systems with In Our Own Voice, ending the silence. So it's out there. We are having a lot of calls come in, believe it or not, from students themselves saying the lack of services that are being in the school system. So right now, I have been asked by Nami, California to be one of the regional experts to get Nami on campus in the high school system. So Nami is working with that. I see Linda Baldwin back there. She works with Ventura County Unified. She's also a Nami family member as far as in our organization. And Ventura Unified and Oxnard Unified is working very, very closely with Nami. Also, I see Mrs. Pritchett in the room, and I've spoke as well as some of our Ending the Silence programs, going to educate counselors, administrators. There's the Ending the Silence program, also has it for family members, and it also has it for the students. So it's becoming very, very prominent that the students are feeling that their most type of what they call mental illness, and I think that's kind of where we've got to look at, is definitely where they're feeling anxiety most of all. High school today is totally different from high school in my day. It is now where the pressure of the higher curriculum is going in for them, and not only that, just the peer pressure that they're getting, and bullying and more things that were more prominent is affecting them. So we did go out to Thousand Oaks High School, and we did talk to almost 50 students, and there was one teacher there, and there was about 6 adults there as well to want to hear and bring this forward. And it is something that the schools are starting to address, and Nami is partnering with the schools to try to get Nami on campus, and that's going to be any age really from middle school on up. But the questions are still in the development stages, and even around the 6th grade, 5th grade session as well. So it is going to take all of us to try to come together and try to assist the school districts, because a lot of them, students go and they go to a counselor, or they go and ask for the help and assistance, but most of the counselors are so busy with educating, trying to get the students prepared to get out of school, that some of those services are needed, and especially resource manuals are needed in the schools. So we are working with that, and I have talked to Kieran as well about Nami partnering to get into the school district.
Yeah, to your point, and I think Ventura County has a lot of, I might not need that, but Ventura County has many resources, and I work in at Ventura Unified. I'm a school psychologist. And my question with that is because there's so many resources out there to have one database where we can really go to, and it's insane on how many great resources for different trauma, suicide risk, all of these things, where we can really, like counselors and psychologists, where we have this at our fingertips to really provide these resources, because they're there. I know they're there. Is that out there? Is that something that's created because the counselors and the psychologists want to provide these resources. And yes, so they're there, we just want to access them.
Well, as we just said, as we can already hear, there's a lot more work for us to do. And it's for us as well as from county facilities to other facilities without this county, but all of you. And so what I'm already putting out as a big thing on the top of my nose, we need more forums like this, and we need to be collaborating with each other. Because in this room today, there's a lot of different partnerships of telecare, Turning Point, and that is going to be one of my resources. And I guess I'll turn towards my old boss and my supervisor, is that I would hope that when we develop that, if there would be any kind of that we can have this type of panel discussion again, because I think it's important for all of us to let you hear from us directly, like today, that maybe things that you're hearing are not out there. So once we start that and collaborate amongst ourselves, then I would like to see at least another maybe 4 times a year that we would have some kind of session like this, because I think from being an ex-county employee, I can only say that County of Ventura certainly stands as #1 in a lot of areas, and I do know each of these individuals up there, and their compassion and their heart is definitely out there to help this community. So I want to thank you again for all that you do.
Thank you, Ralph. I would say nobody is the first boss. You know I say that with affection. And so, yes, absolutely more of these sessions, better understanding, including up here. I also want to say to the psychologists out there, not obviously I'm a layperson, not a clinician, but I've had that same question. I want to get my arms around sort of just a very summary way of looking at all the different programs along the continuum. So there is that. We need to get it out there. We need to get it on the website. From a clinician standpoint, we need to make sure it's there. It may be there, but the prompting your question is prompting me to want to go make sure that it is. And we also work very closely with 211 in making sure that they have updated information, because one of their top 3 referrals, I think, the questions they get are related to mental health issues.
And to have the students know that there is 211, for example, I think that is really important. I mean, we can have all the services in the world, but I still have students, Westlake High School coming up to me and going, I know someone who really needs help, what should I do about it? Going, boy, that she's asking the supervisor that, just tells you right there that there isn't that knowledge in the student base, that there are resources and how to access them.
Really quickly, Janice Gardner, became a advisory board. There is a county that, upon registration of students, when they go back to school, they have a card that gives them the suicide hotline, perhaps an equivalent of 211, and so on and so forth. So it might be something that we might want to think about doing for students, as they register, and they get their books and their content, what their curriculum and so on, that they have some of these resources, which is what I put out there too.
It's interesting. I know there was legislation to make that possible as well. I don't remember the author's name, but I can follow up with that. We have a question right behind you.
Yeah, hi, my name is... Hi, my name is Lucille. I'm a community organizer with Cause, and so we have the pleasure to be able to work with youth. I particularly work with youth in Oxnard. My coworker works with youth in Ventura, also working with youth in Santa Paula. And that's been one of the biggest concerns, and it's great to hear from administrators and directors at this level of the programs. But I think some folks touched on the reality that students don't know that these resources are available. Once a year, we gather as committees, and that was a concern in all of our committees in Santa Paula, and Oxnard, and Ventura, that they don't know, one, that there is a psychologist, a counselor, anything on campus. They don't know where the office is. They don't know how to access it. And then when there are in these programs, because we have a number of students that are in these programs, there's no retention. So they see this counselor, and that retention is lacking, as well as how much of our counselors are culturally competent. And that makes a great difference when you're trained, when you come from the same background. We have a large Latinx population, large amount of our folks that are coming from immigrant backgrounds, LGBTQ. So I think having that cultural competency and doing more around education in our schools, Ventura is taking on and I'm glad to hear that folks from Ventura Unified are here because they're really taking on mental health as one of their big campaigns for the youth program there. So I definitely would like to offer cause as a partner, but expressing that the first step is getting people in the door. And if people don't know about these resources, then you can have the programs there, but they're not getting in the door, they don't know, and how are we gonna retain them more than anything?
If I may just, so thank you for those comments. Really appreciate them. And I know that Behavioral Health is working with the community out in Santa Clara Valley to deal with these issues around disparities and so forth. And it was referenced earlier the Logrando Bienestar program that was started. That had 4 outreach workers, and their main goal was to go out in the community and educate. Make sure families and schools were aware of the services that are available. It's never enough. The good news is they're actually just going to initiate a big expansion of that program, so there's more to come, but we have more to do there. And I know that the department is really emphasizing bilingual staff as well, and so I think they're doing a pretty good job of it. It's a challenge, but it is a real priority for them, and there's additional compensation to incentivize that as well for those clinicians that are bilingual as well. So more to come, and we definitely want to have cause as a partner. Thank you.
I just briefly want to share 2 things. Something that I think fits with this. At the state office, we're working on a youth symposium. And I'm really big about if it's about youth, we need to include youth in that process of even developing the agenda from everything. So there might be some follow-ups from me to essentially share the opportunity with young people here, but more so for you to also hold us accountable. Because youth is not our specialty, I'll be honest with you, but I think that we see a lot that can happen the more we intervene and we get individuals involved in that conversation to raise awareness early on. My second thing is the cultural competency trainings that Nami, California puts on. They're via webinar, so folks can access those in any part of the state. I've had a lot of county behavioral health staff. That was not our original intention. But I think that it expresses the need. And so I've had a lot of staff reach out to me. It's about an 1.5-hour long webinar. There's 3 modules. It goes through the principles of community engagement. It teaches you how to work with diverse communities in a meaningful way. It's not the end, but it's definitely a tool that can assist individuals that are working to engage diverse communities. And so all of that should be up on the website, and that'll be something that I share in a follow-up email as well.
Excuse me.
Yes.
So culture competency, is that focusing on also recovery culture competency?
That's a great question. I'll be honest with you, I don't think it is.
Focus on wellness and how to holistically, culturally, and make that the movement going on.
That's a great question.
And I can help with that.
I will share with staff. I will tell you, in addition to that, we're working on a simple, engaging grassroots in growing those efforts. So we're working on a webinar that could be something that we include and highlight and reach out to peers, because I think that it's very important. And I will tell you, at times, the peer perspective is left out of the conversation. So.
I would like to add that I'm very excited up north. They already have it in place. That in order to be an employee of the county, they have to go through the process of a recovery cultural competency program. And I have that program.
Can you share that information? I would love to follow up with you. Yeah.
Yes, thank you. I'm Diana Hernandez, and I am a proactive peer from the client network. I'm the administrative assistant. And I go to the boards to oversee what Ventura County is doing with the money and which programs are being in place so they meet the needs and interests of the people. Thank you.
Thank you. Yes.
Yeah, I have a question and a comment.
Okay.
One, I'm just bringing it back around to John, why hasn't the Board of Supervisors sent a letter to the state asking for the state to apply for the IMD exclusion waiver? So that's my question. My other comment is, in terms think it's important for the group to know that there's a whole body, or two bodies of law that give students entitlements to services, including mental health services. So I don't like to be stingy, but I think we should protect, to the extent that is appropriate, our mental health funding, and push off from the schools what they are entitled, what they should be paying for.
I agree with part of that statement, and I will tell you that there is funding that is kicked out from the states to support mental health services in the schools that doesn't come from MHSA. And I will tell you that there is Senator Bell, specifically, who is working to try to expand LEA relationships with schools to deliver mental health services. Regarding the IMD, I can't speak to that, but I will tell you, a lot of people are frustrated with how slow the process is moving. I've been a part of the stakeholder meetings in Sacramento with DHCS, and it's like pulling teeth. It's very hard. I will tell you that the more individuals that we can get to the meetings to show, hey, this is the issue, what's happening, I think the louder we can become, and they might move a little swifter.
And I would just say the county has sent letters and in favor of that, and the issue now is that it expires, so we are looking at, and it funds not only mental health, but our entire healthcare agency, and as we look at that expiration date coming, I believe it's in June of 2020, we'll be moving for the whole package and including the IMD waiver.
Yes, just to echo that, the board is actively engaged in wanting to advocate on this because it's ridiculous. So, sorry, just to be blunt. But it is part of it. It's not just the funding for our county. It's the entire what's called, forgive the technicality, waiver, Medicaid waiver that the federal government has with the state of California. It's all wrapped up in that, and it is excruciatingly slow. But what's happening right now is we're lobbying to make sure that as part of the negotiation for the next waiver, and that has to start now, it is starting right now, but this is the key component of that negotiation process.
Can you briefly, and this might not be possible, for those that might not know what IMD is, briefly share what it is and how it's utilized or how it can be utilized?
IMD stands for Institute of Mental Disease, and it's basically a requirement that the people who are there are confined, and that's the only way you can confine people essentially against their will, and that's what an IMD is. The IMD waiver is I can pass on that over to you, but essentially the funding that is being restricted for the patients there is something that we're looking at, making sure that it's incorporated when we do our negotiations, which are processing right now.
Maybe that should be talking about from a clinical standpoint.
Yeah, for purposes locally, the cutoff, so to speak, is 16 beds, and so that's specifically why Horizon View has 16 beds. They can operate not as an IMD. For us, we contract with Silmar, which is technically an IMD. They have 208 beds, and like the supervisor was saying, it's essentially locked psychiatric treatment, and it follows that the folks who are in IMDs are people who are generally on conservatorship. Usually it's LPS conservatorship, not exclusively, but primarily. And it is, from a clinical standpoint, it's something of a balancing act. There are certainly some people who require continually only benefit from blocked psychiatric placement because they're so resistant to treatment. That said, generally the court views block placement with some real hesitation. There's the law will direct us, directs the court essentially to assure that the person's in the least restrictive level of care, and that really follows from the fact that if you can gain somebody's agreement and compliance with treatment, your prospects for long-term treatment are much better than if you're in the unfortunate position of having to force treatment upon somebody. And so whenever you are in that kind of forced treatment situation, from our standpoint, the goal is to try and mitigate it and make it the shortest period of time, primarily used to sort of convince and cajole and people that it's really in their benefit, to help them see the benefit of treatment, so that they then elect to continue with treatment after they're quote unquote required to do so.
So I think we have time for 2 more questions. I did receive a lot of questions regarding CIT, how the county currently implements CIT, what does the team look like? And so if we can spend the next 5 minutes or so briefly explaining how that operates, maybe how it's funded, and I know that we have experts in the crowd as well, if you're willing to share. I think that's really important.
All right. Was that the question? So our CAT program, it's been here in Ventura County for 18 years. We're funded by a combination of things. We receive $100,000 a year from behavioral health department that funds about a third of the program. The remaining fund comes from a contribution by 6 agencies in the county, Sheriff's Department and all their contract cities, Ventura PD, Oxnard PD, CB, Fort Wayne, and Santa Paula. They're all paying partners to the program. When we began the program, we followed the Memphis model. It's a 40-hour program that started in Memphis, Tennessee in 1988. Since then, we've trained over 1,800 law enforcement officers in the county. We're one of we're the only Memphis model county-wide program in the state of California. We have every single law enforcement agency participating. Even the non-financially contributing agencies, we allow them in whenever we have vacancies for the training. But our primary thing that we do is we train law enforcement and the signs and symptoms of mental illness. We teach them de-escalation skills, teach them how to deal with people when they're in crisis. It tends to primarily deal with people who have mental illnesses, developmental disabilities, but really the de-escalation techniques that we teach are universal, whether you're handling a domestic dispute or somebody that's upset over a parking ticket. So, I think it's gone a long way. I've been in law enforcement for 32 years now, and I can tell you that in spite of what you read in the news and see on the TV, the profession's gotten better. Because of body-worn cameras, we're seeing a lot of the bad stuff that happens across the United States. But I can tell you, we've had body-worn cameras in Ventura County for at least 6 years, and we're not making national headlines for the bad behavior. And although we all know in this room it's difficult to measure prevention, but I can tell you from my 32 years experience that it's changed. Things are a lot better here than they used to be before we started CIT. Oh, I'm sorry. My name is Mark Stadler. I run the CIT program administrator. Scott Walker's here also. He's a CIT program assistant. So my background is law enforcement. I started with the city of Santa Barbara for 3 years, then I retired 4 years ago as a commander with Ventura Police Department. And then for the last 4 years, I've been running the program here for the Sheriff's Department.
So Scott, could you please, I'm sorry, not Scott, I'm Mark. Could you please tell everyone how you've invited Nami to the academy, to your academy training, and then also the new post-it notes that you've developed when you go out to a scene and how it does say about the Nami.
Yeah, one of the strengths I think of our program is that we bring in a lot of outside speakers. It takes about 50 to 60 instructors and guest speakers to put on a 40-hour training class for law enforcement. We have anywhere from 30 to 50 law enforcement officers in each class, and we do 3 classes a year. And Nami is an extremely important part of that, because bringing people with lived experience that can come in and talk directly to our law enforcement officers to express how law enforcement's impact them. And we ask them, we go, don't hold back. Tell the officers exactly what's happened, bad experiences, good experiences you've had, because they need to hear it. And we also bring in law enforcement officers who have family members who are impacted by mental illness or developmental disabilities. We have them come in and talk about their own personal experiences, and so they get that peer-to-peer with their fellow law enforcement officers understanding that perspective. And regarding the post-it notes you're talking about, that's something Scott Walker
you already happy to do Marcel?
Yeah, so that's something that Scott put together. It's a great tool. We hand it out to all the law enforcement agencies in the county. It's just a quick little reference that they can hand to people for a few of the services. You know, we offer information on any services that we think will help people. It's one of the things we do train on in our CIT program is what services are available. You know, there was a lot of talk when we first started CIT that, well, it's going to be this touchy-feely, huggy kind of thing, and you know, not going to work for law enforcement. It's going to take forever. But we were in the beginning, we were keeping the statistics on it, and it actually showed that a CIT trained officer would handle a mental health call in 63 minutes, and a non-CIT trained officer in 92 minutes. And that was because the CIT trained officer understood what the problem was faster, and they knew what resources were available to be able to be more effective. The thing that's really hampered us in the last few years, it was touched on here earlier, is law enforcement's being tied up a lot in our local emergency departments. The process we have now is that law enforcement has to go to the emergency department first. We can't do any direct admits to home. And unfortunately, that is due to a lack of the CSU chairs and the inpatient beds. But we have seen some positive signs here recently. The 4 chairs opening up at CSU is tremendous. We may at any given time on what the Belmont calls their outlier report, there may be 8 to 10 patients across the county and emergency departments waiting to get in. So do the simple math. If we can open another 8 CSU chairs and get the other 10 beds that are available at Belmont opened up, that's 18 more spots. It's going to cut down on those delays in the emergency departments, and it's not appropriate for anyone. It's not appropriate for the person that's in a psychiatric emergency, and it's also not appropriate for the 10-year-old that just broke his arm and he's sitting in the bed next to someone who's having a mental health crisis. So the emergency departments aren't trained for that. When someone's sitting in an emergency department waiting to get into behavioral health, they're not getting psychiatric treatment. They're just being stabilized and contained and waiting for someplace to go. And on top of that, you have law enforcement that is assigned to stay with them because the hospital staff doesn't feel safe. And so now you have people who could be handling 911 calls are now sent to the emergency departments, acting as security guards.
I just have to say too that, you know, exactly what you say is true regarding the IV beds. As we had mentioned, it's great to have the new ones coming out of the board as well as CSU. But also, I just want to talk about how incredibly
can summarize it as it puts it into a map of where the person is in crisis and how to address it.
Oh, no,
And
I've spoken at that before, I know. But
I'm not speaking to you personally. I say thank you to all your additional comments. I just want to thank Scott, because Scott does get around, and I don't know how many people that you have affected, both the officers, sheriffs, and the laymen. So thank you, Scott.
Bravo.
I'll just add in there that it's a community effort, so we rely on many of you to help us support our officers and to conduct our training. So if you look at our CIT Academy, we might have 30 to 40 students, but we have 75 instructors, guest speakers that come in from a variety of agencies. So a number of faces here in the room are actually presenters at my CIT Academy. So thank you all as a community.
All right. Nami, Mayor of the Advisory Board. I really love your CIT program, no question about it. I've attended and presented so many times that I have my own CIT pin. But, you know, I'm on the Nami helpline as well, and Nami support groups, I lead those. And I still hear from so many family members when they call for someone who's having an episode, they need help dealing with that, CIT officers come. And if that person even resists or struggles with what the CIT officer instructs them to do, they do still get arrested and taken to jail. And, you know, I'm really suggesting here that perhaps the sheriff and the chiefs, you know, give some more policy information so that when someone has really not committed a crime and in the process of being helped by the CIT officer, there's no reason to take them to jail. We need to go back into treatment. So if you could help address that, that would be great.
Sounded more like a statement than a question, but I don't disagree. I don't disagree with you. I mean, obviously that's what we're trying to do with the CIT program is divert people away from jails and get them back into the treatment they have. I mean, the reality of it is law enforcement by default has become the crisis response team for mental health emergencies. And we're constantly looking at laws and changes and how to better handle things. There's even a push now for a more disengagement in the sense that we respond to mental health emergency, and rather than rushing up to the door, we wait around the corner, make a phone call in, and try to figure out a way to not have a uniformed person with a gun be the first person on scene when you have someone with a mental health emergency. The reality that happens a lot because our crisis team, our work for behavioral health, there's limited availability of their response. And, you know, we're out there on the street 24 hours a day, 7 days a week. So if we get a report for crisis, we can't say, too busy, sorry, that's not our thing. We go there and we make sure that things are stabilized, and then we try to get the mental health professionals there. I mean, when we do our 40-hour class, we make it very clear to law enforcement, we are not training you to be a clinician. You can't do that in 40 hours. But we can teach you to recognize the signs and symptoms, and teach you some techniques to de-escalate the situation, to keep you safe, and keep the people safe that you're encountering and the family members.
I would just add to that real quick. You couple that with the expansion of the RISE program, the co-responders having the mental health professionals go with the sheriff and the police. The establishment of the crisis stabilization unit gives officers in the field more choice because the standard for the inpatient admission is very high. And now they have more choices in that. And again, I want to emphasize those year-round shelters are going to make a big difference. And again, it gives the officer a choice. Do they take them to jail or do they take them for service? They need to take them for services. So.
Hi, my name is Mary Hafner. I currently serve on the BHAB, the Behavioral Health Advisory Board for Ventura County. And there's a couple of things that I think, everything is so related, and I think we see what an enormous problem this is. And it affects everyone in every sector. And so I think one of the things that is most important is to understand there's a difference between the people who have SMIs, serious mental illness, and people who have anxiety or some other issues, okay? There's a difference. There's the worried well, and then there's people who are suffering from thought disorders, schizophrenia, and psychosis. So it's really important to delineate those groups. And 50% of people with SMI are not receiving treatment. they do not receive treatment. And that's what we're dealing with, a huge population of people who have a very serious illness. And so one of the most important things, and John Schipper really touched on something important, there's a foundational piece here that's important for our policymakers, our legislators to be educated. What does SMI look like? How does it manifest in someone? How does it rob them of rational thinking? I mean, they're not even able to think rationally. They're not able to put thoughts together that make any sense for their well-being. So there has to be a foundational educational piece for our policymakers and our legislators to understand what SMI truly is. That way, they can understand what is the best way to help them. So it's a foundational issue, and one of the things is we have to understand is what Dr. Schipper said. You can't prevent schizophrenia. You cannot prevent serious mental illness, but you can prevent further deterioration. So basically what's going to happen is people are going to have their first psychotic break. And he's right, people are in denial. Yeah, my kid is acting kind of strange and kind of weird, I don't know what's wrong. Well, nothing's going to happen until that child, that young adult has a psychotic break. Boom, that's where we got to be doing our work. Our work needs to be surrounding and supporting that young person who has their first psychotic break. And the only way to do that is we need LPS reform. And part of that is redefining the criteria for involuntary commitment with terms that are objective and based on scientific medical standards. We're not doing that right now. We also need to reclassify serious mental illness from a behavioral condition to a neurological medical condition. And that will unlock more medical research and funding. We have to be realistic. Some people have serious mental illness, and we've got to be realistic about what it is going to take to truly make a difference. And these are the people that are cycling in and out of jails. These are the people that are cycling in and out of homelessness. And that's because as they continue to do that cycling, they continue to further deteriorate, and then their long-term prognosis is not good at all. I just want to make that statement. Thank you.
All right, so we have time for 2 final questions from the crowd.
I just want to ditto very much what Mary has just said. And that's why the intent of the Mental Health Service Act, the initial intent was with the seriously mentally ill. We diverted our priorities from that to wellness, to the mentally health, the health of the mental. Not the word, thank you. But it was to address these very serious issues. And Mark Statler, thank you for the reality check. And he was very much knowing that the crisis was where that initial step would be for the mentally ill. And it was never developed. Why are we wasting our time? It's been over 10 years, and we're at the same place. Why? I mean, I am passionate about this. I mean, it's because I have a son with a thought disorder. And it's just, they cycle, they will use up the services that are there, and it's just, we go off into all these other places, and it just does
so many times, I can't even tell you. I've cried when I heard how gentle and thoughtful they talk to my son. And sometimes he can be extremely difficult. So again, with passion, CIT is so good, and really don't hesitate to call for a CIT officer. They really do understand. So again, thank you.
I have one final question. Gentleman on next over Tom.
Can I just say one quick thing? Sorry, Janice Carter, Behavioral Health Advisory Board. We have formed an LPS work group, and that is Lantern and Petrus Short. We also have the creator of the reform of the LPS speaking at our work group meeting this coming Monday. So we are, looking at this.
So I might, before you speak, I might be in touch with you because I'm currently working on a 30-second survey. I met with Senator Morlock, who is very passionate about trying to fix some of the flaws in our law, specifically with gravely disabled LPS. So you should see a simple question from me: what are some of the issues with the law, and then how, if in a perfect world, what would you want to see in the definition? So I'm working on a little project to provide that information to the legislature. So please be on the lookout for that. Go ahead.
My name is Jerry Harris. I'm the past chair of the Behavioral Health Advisory Board and a governing board member of the California Association of Local Boards and Commissions. I agree 100% with what Mary said. We have a situation where LPS was set in place in 1962 or 63, and it hasn't changed. Science has increased, the way we treat people has increased, but not the law. So at this point, the law is preventing a core group of people from receiving treatment. These are people who, because of their condition, lacks the insight to even know that they are ill. So we need to look at that. We need to address that, because if you lacked insight that you're sick and you need help, and even if your family wants to get you help, how would you feel when you're just flatly turned down because you don't meet criteria of the law that does not recognize this group of people? And even on the waiver issue, I was in Sacramento and I asked the executive director of the California Behavioral Health Planning Council what their group's doing in terms of that situation, the waiver. And I was floored when she told me that their members feel that because it may add additional involuntary beds, they might not support it. But each of us are different. Each of us have different requirements for treatment. Some may only need 3 days. Some may only need a week. But there's this group of people that need and deserve long-term care.
It's actually 11:15. So anything that
This is huge, okay? There's first off, recovery is a spectrum, and recovery is individualistic. On top of that, there is a population that does not have substance abuse, okay? And that needs to be addressed also. Where do we put, where do we go? Are we going with the housing of the criminals? Are we with the substance abuse when there's so much, when the board, what about that population?
Thank you. So it is 11:15, so I do want to give thanks